Добар ден на сите. Ве посакувам добре дојде на 8-миот вебинар во серијата на вебинари Светските експерти за аутизмот, гости на Македонското научно здружение за аутизам. Македонското научно здружение за аутизам го одржува континуитетот на овие вебинари и денешниот вебинар ќе биде на тема депресија кај лица со аутизам, ќе го одржи професор доктор Мохамад Газиудин. Најпрво ве замолувам вашите камери и микрофони да останат исклучени за време на предавањата, а подоцна ќе можете да се вклучите во живо во испланираното време за дискусија. Пред да преминеме на главната програма за овој вебинар, Македонското научно здружение за аутизам денес подготви изненадувања за сите кои што се присутни на овој вебинар. Особена чест ми е да го представам Матеј Никојски, млад господин со Аспергер кој што одлично свири на пијано. Денес ќе ни отсвири 2 numери на почетокот и 1 numера на крајот на вебинарот. Особено ни е чест на сите да го слушнаме, да го направиме овој вебинар доста интересен со тоа, а и да принесеме за инклузија. Сега ќе споделам кратката биографија на пијанистот Матеј Никојски. Матеј е роден на 9 октомври 1993 година во Скопје. Во 2013 година завршува музичка теорија со педагогија на Факултетот за музички уметности во Скопје. Потоа стажира 3 години во Македонската опера и балет. Во 2016-2017 година магистрира на Факултетот за музичка уметност, музичка интерпретација со корепетиција. Со концертни настапи започна уште како ученик во Илија Николовски Луј, каде оствари 20 јавни настапи. Подоцна за време на студиите одржи уште 20 концертни настапи. Во текот на студирањето активно учествува на меѓународни такмичења надвор од земјата во Србија и во Македонија, на кои има освоено 4 медали, односно награди, од кои што 3 се први и 1 е втора. Покрај тоа Матеј Никојски учествуваше на 2 хуманитарни концерти во текот на студиите. Концерт на ФДУ Скопје и концерт во дом на ЈНА, односно тогашна филхармонија. Настапуваше и на концертна вечер на пијаното во центарот Гуарнериус во Белград. Помеѓу колегите е познат по неговото добро познавање на музичка теорија и особен афинитет кон хармонијата во музиката, читање од лист, апсолутен слух, памтење на обемен нотен материјал, но и подобрата соработка и интерпретација на музичките дела од различни периоди на класичната музика со колегите кои ги корепетира или пак самостојно. Најголемата пасија на Матеј останува музичката теорија и хармонија, а најголема љубов во која сака да се реализира е корепетиција, односно да биде акомпанист на оперски пејачи или инструменталисти. На почетокот првата numера ќе биде од Јохан Себастијан Бах, Invention No. 1 во C major, и втората numera исто така ќе биде од Јозеф Хајден, Eine kleine Serenade во F major. Повелето магистар Матеј Никојски, чест ни е да го слушнеме вашиот настап. Благодариме многу на овој извонреден настап. Навистина беше прекрасно и сигурна сум дека сите гости, исто како и мене, уживаа во настапот и дека едва чекаат да ве слушнат повторно со третата номера на крајот на вебинарот. Ви благодарам уште еднаш. Сега можеме да продолжиме понатаму. Би сакала накратко само да напоменам дека за време на предавањето ќе бидат достапни белешки на македонски јазик, кои што ќе можете да ги вклучите на копчето CC Live Transcript, а подетални инструкции ќе бидат поделени во четот. И сега му давам збор на председателот на Македонското научно здружение за аутизам, професор доктор Владимир Трајковски, официјално да го отвори овој вебинар и да го представи денешниот предавач, професор доктор Мохамад Газиудин, и повелете професора Трајковски.
Благодарам, колешке Ивановска. Имавме една одлична прилика денеска на еден невообичаен начин да го започнеме денешниот седми вебинар, мала корекција за Андреа, седми поред, почнавме мај-јуни и посакувам на сите добре дојдовте, веќе се зголемува бројот 94 учесници, навистина имаше и преку 200 пријавено, но добро, ја реков дека ќе бидам задоволен да имаме денеска и 100. Сега ќе ми извините, но јас морам да преминам на англиски, за да го представам нашиот гостин, а потоа ќе имате прилика во наредните 45 минути и да чуете навистина едно извонредно предавање, бидејќи го познам долго време. Now, I want to introduce our speaker for today. This is Professor Dr. Mохамад Газиудин, who is my friend for the last 20 years. We know each other via internet, but we collaborate in several conferences, or he was reviewer in my previous journal and also in my journal now, which I'm leading, Journal for Touch Therapy and Developmental Diversities. Professor Dr. Mохамад Газиудин was born and raised in Hyderabad, India, and after graduating from Osmania University in 1980, he obtained higher training in psychiatry in London, where he obtained his membership of the Royal College of Psychiatrists. Subsequently, he moved to the University of Michigan, Ann Arbor, USA, where he trained in child psychiatry and obtained research experience in autism and developmental disorders. Except for visiting professorship and academic visits, he has spent his professional life in the US at the University of Michigan, boards of psychiatry, neurology, and child and adolescent psychiatry. Dr. Газиудин describes himself as a clinician, researcher, and educator. His main areas of research and clinical interests include the phenomenology, classification, and the comorbidity of autism spectrum disorders. He was among the first to systematically study the distinction between autism and Asperger's syndrome, and also explore the psychiatric comorbidity of autism spectrum disorders. His book on the mental health aspects of autism and Asperger's syndrome, published in 2005, was the first book on this topic in the world. He is also a dedicated teacher who has taught and mentored trainees in psychiatry, both in the US and overseas, author of about 100 publications, including peer-reviewed research, articles, book chapters, and books. He has traveled and lectured widely. He is a member of several professional organizations, including the American Academy of Child and Adolescent Psychiatry, and has served on the editorial boards of several prestigious journals and advised governmental agencies about child mental health with particular reference to autism. Now, I want to give the floor and to ask Professor Газиудин to switch on his camera and his audio. I'm really glad to have him today with us because he's one of the leaders in the field of psychiatry of autism, and he will give the lecture about depression in autism spectrum disorders, which is a really interesting issue with the children with ASD, or adolescents or adults with ASD, especially of adolescents and adults with Asperger's syndrome. Professor Газиудин, please switch your, I hope that you are ready for your presentation. Now I will switch off my microphone and camera and will give you 45 minutes or much more if you wish. Good luck.
Thank you very much, Dr. Trzaskowski. As I told you earlier, it's my delight, my honor, and my pleasure to be here amongst you all today. Good evening to the organizers of this talk, and thank you all very much in advance for giving me this opportunity to interact with you, even though it is virtually. As Dr. Trzaskowski told you, I'm a psychiatrist by training, and so I cannot but only talk about the psychiatry of autism. My presentation today is specifically going to be on depression. And before I do that, let me try to share my screen with you, if I may. Okay, can you see me?
Yes, yes, perfectly. Please go on.
Is that okay?
Yes, yes, please.
Okay, let me just get my orientation right. So this is the topic that Vladimir asked me or agreed with me that we should concentrate on, because autism, although it's a childhood diagnosis, children with autism become adolescent. Can someone switch off their microphone, please? I'm hearing a lot of echoing in the background. Thank you. So I'm going to speak on depression in persons with autism, and this is meant mainly for non-psychiatrists and non-experts in this in the psychiatry of autism. I was told that the majority of the audience, most of the audience, will consist of educators, parents, and other people not directly connected with psychiatry or indeed with medicine. So without further ado, let me, okay, so the overall goal of my presentation is to increase the awareness of depression in persons with autism across the lifespan, although the focus will be on children and adolescents. As and when appropriate and necessary, we will also talk about how the condition presents itself in adults with this condition, with this disorder. The intended audience are the educators and mental health professionals and doctors, of course, and parents. The intended outcome of this conference, of this presentation, is that we will, by the end of this presentation, increase our understanding of autism, talk more, examine in detail about its presentation amongst people with autism, and also, if time allows, to discuss about the causes and the treatment. So before I do that, it is important that to briefly review about what autism, about the outline of the presentation. Let me just try to switch this up. Okay, so the first question that we will deal with briefly is about autism itself. What is autism? I will describe briefly about the classification of autism, and then we will talk about what depression is in the context of today's presentation, and we'll try to address the question if depression can occur in people with autism, and if so, how does it present itself? What are the distinctive features in different types of autism? Because as you know, autism is not one condition. And what are the causes and risk factors and complications? As I'm sure all of you know, the story of autism began over 70 years ago. Autism as we formally know of it today. And we owe the description of this disorder to a child psychiatrist, Leo Kanner, in some ways underscoring the importance of this condition to psychiatrists, to people who belong to the mental health professions. So Kanner described a series of children at Johns Hopkins University in the US who he believed shared certain common characteristics. He was an expert in trying to see commonalities in the symptoms, and these symptoms mostly consisted of problems in what he called affective contact. Affective was not used in the sense of depression, but in the ability to connect with other human beings. The other core features of these children were that they had problems with both verbal and nonverbal communication, and they had ritualistic interests and behaviors. Subsequently, after several revisions, the diagnostic criteria of autism were proposed and accepted. And now the condition has gone through several revisions, and the diagnosis itself has expanded to include Asperger's syndrome, Rett syndrome, disintegrative disorder, and related conditions under one umbrella category of autism spectrum disorder. So although ASD or autism spectrum disorder is used as a shorthand now to describe people with autism, in my opinion at least, it consists of several distinct and sometimes overlapping subtypes. And it depends partly on what your own approach is, whether you believe that it's one condition or different conditions with overlapping but different etiologies. The prevalence of autism has increased tremendously. Originally, it was thought to occur in 4 per 10,000. Now, in 2021, it is said to occur in at least 1 per 100, if not more. It occurs in all cultures, in all countries, all over the world. I'm not sure what the exact prevalence of this condition is in Macedonia, but I'm sure it is at least 1%. The prevalence has increased due to a number of reasons. There is increasing awareness, changing diagnostic criteria, and sometimes the reasons are purely administrative. The condition itself is more common in males, like just as all neuropsychiatric, neurodevelopmental conditions are more common in males. This condition is also more common in males. Symptoms usually appear before the age of 3 years, and at least in the Western countries, they are almost always apparent or diagnosed by 4 to 5 years of age. In some children, the symptoms may become more obvious during adolescence, especially in those who have what is sometimes referred to as high functioning autism, in which the IQ is normal. As you know, when the condition was initially described, it was assumed that the bulk, the majority of the affected children had intellectual disability, to the extent that the general assumption, the teaching has been that about 75% of children with classic autism or traditional autism had intellectual disability, previously known as mental retardation. And only about 20 to 25% had normal IQ or normal intelligence, and these have been traditionally described as having high functioning autism. So in many children who have normal intelligence, the symptoms of autism may not be that obvious in the early stages of life, and as they grow older, the demands of society, the demands of adolescence, the challenges of growing up, particularly interacting with peers is concerned, those issues may come more to light and leading finally to their diagnosis. So even in the West today, my practice mostly consists of children and adolescents and adults with autism. I still see missed cases of autism being diagnosed for the first time in their late adolescence, and sometimes even in adulthood. Speaking of which, the symptoms usually persist in adulthood. They do not suddenly disappear once the child reaches the age of 18. And there is a great deal of interest and talk about the recovery from autism or the cure of autism. But in my view, it depends entirely on how you define it. We have already discussed about the classification. It can be classified into high functioning versus low functioning types, depending on the level of IQ and communication skills. It can also be classified into severe versus mild, autism with or without neurological conditions, Asperger's syndrome versus autism, etc. The diagnosis depends clinically on the unique cluster of the three core symptoms: reciprocal social deficits, communication deficits, and restricted interests and behaviors. These are the core symptoms that, for some reason that we do not quite understand, occur together in the same individual. This mystery we have not been able to solve so far why they cling to each other. So the diagnosis depends on showing the occurrence of this unique clustering of symptoms. There is no blood test, there's no imaging technique, there's no specific neurological test. I am aware that there is a great deal of interest in instruments and observation schedules. However, based on my experience and that of others, these instruments only provide additional information. They supplement the clinical information that they do not diagnose by themselves. The final diagnosis depends, therefore, on clinical judgment. Treatment, as I'm sure you know, consists of both conventional methods and unconventional methods. Conventional is behavioral intervention, social skills training, educational placement, speech, occupational therapy, with medications used appropriately. There are also several unconventional methods, and I will not discuss those at this time. Early intervention or childhood intervention is a name given to a group of services that are traditionally used in children with autism. Can you grow out of autism? As I alluded to earlier, it depends on how you define it. Experience suggests that by and large, the symptoms do not go away, even though in some individuals, the symptoms may decrease to the extent that they are not clearly recognizable. these individuals still continue to have the need for services, and the services that they often need are of psychiatric in nature, mostly for mood symptoms such as depression, about which we will talk in a minute. The outcome of autism is traditionally depends or has been described as depending on two main factors: the level of IQ and the presence of good verbal skills. However, there are also secondary factors, and these are medical factors, medical comorbidities such as epilepsy, and psychiatric comorbidities such as depression. So changing gears then, what is depression, which is going to be the main topic of the presentation. We have seen briefly what autism is. Now it is important also to review what depression is, although it will be a much shorter review. Here, when I talk about depression, I do not talk about just a mood state, because we all go through periods when sometimes we feel sad, sometimes we feel angry, sometimes we feel happy. When we feel sad does not mean that we are clinically depressed. But when we talk about depression in this context, we refer to a disorder characterized by persistently sad mood, which is accompanied by loss of interest in enjoyable activities. And that which is characterized by both psychological as well as biological symptoms, such as loss of sleep, loss of appetite, etc. If untreated, it can cause significant complications, including problems with marital life, occupational life, self-injurious behaviors, and last but not the least, suicide. There are several types of depressions. For this presentation, we'll focus only on major depression. So this now brings us to the next part of the presentation, which reviews the definition of comorbidity. In this context, we use it only to describe the occurrence of two or more conditions together. As you can see in the circle here, you have the core symptoms of autism. Then you have the medical symptoms and the psychiatric symptoms. Among the medical symptoms, you have known genetic conditions such as, or medical conditions that you have more named disorders such as intellectual disability, Fragile X syndrome, epilepsy, tuberous sclerosis, etc. And so far as psychiatric comorbidity is concerned, we have a variety of conditions. For the sake of simplicity, we can say that before the age of puberty, the most common psychiatric condition or psychiatric symptom cluster is that of hyperactivity, impulsivity, intrusiveness, the so-called ADHD cluster of symptoms. However, after puberty, the most common symptom complex that we see is that of mood disorders, mainly depression and anxiety, and usually a combination of those two. So the point of all this is that persons with autism can also develop depression. Depression as a disorder, not as a state of mind. In fact, as I said, depression is the most common psychiatric disorder that develops in persons with autism across the lifespan, particularly in adolescents and adults. As more and more adolescents step into adulthood, the age between 18 and 25 becomes critical. And this is also the time when depression and the complications of depression can occur in this population. The exact prevalence of depression is not clear, although it depends on the population and the study. In general, in referred populations, at least 30%, if not more, patients with high functioning autism have depression, but clinically, probably it is much higher than that. studies have suggested that in PDD-NOS, or what used to be called atypical autism, the rates are even higher. And across the lifespan, it's probably the most common psychiatric disorder that occurs in persons with ASD. So what are the symptoms of depression in autism? How does it differ from depression in people without autism? That is one question. But before we answer that question, we should first acknowledge that depression can occur across the entire range, not only age-wise, but also as far as the level of functioning is concerned. In higher functioning individuals, it's important to remember that the main symptoms are those that also occur in those without autism, mainly a depressed mood and increasing withdrawal. And we'll spend a few minutes later on talking about the differences. In lower functioning persons with ASD, that is those who have intellectual disability and major communication problems, the symptoms consist usually of loss of skills, regression, weight loss, incontinence, etc. Now, if the question is, how does depression differ from the depression that occurs in people without autism, you have to first factor in the presence or otherwise of intellectual disability. In those who do not have intellectual disability, the symptoms are slightly different, as I said. However, across the board, there are some special features that should raise your suspicion of autism. If you have a student in your classroom, a 13-year-old who has been functioning relatively well, then once he becomes a teenager, because of increasing demands or because of other reasons, his main interest of drawing, suppose he used to draw, he was interested in drawing human figures, his main interest changes gradually to drawing only morbid figures. He starts only sketching humans who are dying or people who are falling off a bridge. So you can see that how the quality of the drawing, quality of the sketch work has changed, suggesting that there is a very subtle change in the type of the autistic preoccupation, if you would. So the preoccupation now takes on a morbid flavor. And this is one of the early clues that you can see. Or you can also see an increase in obsessive compulsive features. As you know, people with autism have certain ways of doing things. They do things repeatedly, checking and rechecking things, or sometimes washing hands. If these compulsive behaviors increase, they may have an underlying depressive cause, and you have to rule that out. Another symptom that may bring a patient or a student with depression and autism to your attention is when the teenager starts talking about hearing voices, asking that person to do bad things. So whenever there is a suspicion of psychosis, meaning reports of seeing things or hearing things that other people do not hear, that's a very simple definition. Whenever there is a suspicion of psychosis, underlying depression should also be ruled out. What are the other symptoms when a patient starts having frequent crying spells, when there are when there's clear sadness, if there are episodes of aggression, which is a new symptom, somebody who has been reasonably stable all through his life now starts becoming more irritable, more aggressive, or there is more in social withdrawal, and there's a loss of interest in pleasurable activities, along with what we have already seen, a morbid change in the quality of the fixations. So all these factors, all these new symptoms should raise the index of suspicion. And sometimes chronic symptoms can also get worse, like irritability and anger outbursts. Or when a person with autism goes through major life changes or life events, change of school, bullying, death, and divorce in the family. I have seen now COVID being a major stressor that sometimes pushes teenagers to the other side, to the depressive side. And finally, if there is a strong family history of depression, if you have one or both parents who themselves have had depression, or if there is a family history of attempted or completed suicide, especially a bipolar disorder, then depression in the autistic child should also be considered. This is a summary slide that divides between high functioning autism and low functioning autism as far as the presentation of depression is concerned. As you can see, the high functioning group, the important point is that teenagers or those who are verbal enough are able to tell you about their feelings. They are, if you ask them, they are capable of telling you that they feel sad and depressed. The problem generally is with us, and in that I include myself and my colleagues in the category among psychiatrists, because we assume that people with autism do not have the ability to describe their own feelings. This is, in my experience at least, not true at all. And there may be suicidal thoughts and gestures as well, and we can discuss this later if we have time. As opposed to this, the low functioning people with autism, there is the change of behavior is often accompanied by regression or loss of skills, so-called vegetative symptoms. Some patients with autism can also have cyclical mood changes resembling bipolar disorder, and this diagnosis is more commonly made for obvious reasons in those who are more verbal, such as those who have Asperger's syndrome. We have already seen that psychosis can also develop in people with autism who have co-occurring depression. And there are some reports that a sort of thought disorder that occurs in schizophrenia can also be seen in some individuals who have psychotic depression. The point that I'm trying to make is that whenever we investigate a patient who has autism with suspicion of psychosis, we should rule out underlying depression first. A complication that sometimes occurs in patients with that of catatonia, as I'm sure some of you know, that this is a condition described, characterized by a progressive slowing of movements, loss of learned skills, mutism, impairment or restriction of food and fluid intake, and in some cases, extreme cases, starvation, death can occur. So this is a medical emergency. It occurs more commonly in people with autism, perhaps compared to the rest of the population. About 15% in some studies, earlier studies, 15% of people with autism are said to develop catatonia during late adolescence and early adulthood. It occurs in both those who have intellectual disability and those who have normal intelligence. And depression may be a common co-occurring condition along with catatonia. In severe cases, the patient needs to be admitted. Benzodiazepines are the medications of choice because antipsychotic medications make the condition worse, and even ECT may be tried in some cases. Now, depression usually does not occur on its own in clinical practice, although so far what I have presented seem to have given the impression that depression can occur as a unitary condition in people with autism. But in real life, when you see patients in practice, depression is often accompanied by other symptoms and conditions. And these often include anxiety disorders, because anxiety and depressed mood often go hand in hand. At least 30% there is a comorbidity between the two. And these anxiety disorders may include generalized anxiety disorders, selective mutism, social anxiety disorders, etc. In addition to that, ADHD can also occur with the depression. So whenever you have a child with ADHD, especially if there is a family history of depression, you have to rule out co-occurring depression as well. Any patient with aggressive behavior can also have this condition. So the co-occurring conditions here, like oppositional defiant disorder, conduct disorder. Increasingly now we are seeing patients who have gender identity disorder with autism, who present to us not because they have gender identity issues or gender dysphoria, but because they have depression, because they feel that they are being ostracized or being discriminated. Another condition that is now becoming increasingly apparent, if not common, is that of substance abuse, particularly those who are young adults and who have relatively normal intelligence. Eating disorders can also occur in people with autism who have co-occurring depression. And finally, self-injurious behavior and suicidal behavior. So what are the causes of depression in the setting of autism? So the most important, of course, is the genetic contribution. If there's a family history of mood disorders, then the child, the patient with autism is also more likely to have depression. Then there are environmental factors and life events that we have discussed briefly. And usually it's a combination of both nature as well as nurture. Assessment begins with suspicion of autism, taking a detailed history, spending time with possible clues, possible risk factors, the family history, etc., and then rule out the medical causes. This is extremely important for those of you who are, medical doctors in the audience, particularly thyroid dysfunction. This is a simple test that needs to be done, that can be done very easily because of the strong association between thyroid dysfunction and depression in the normal population. Without autism, without mental retardation or intellectual disability, there are certain rating scales that can be used. However, the approach differs slightly depending on, as I said earlier, whether or not the person has a co-occurring communication and cognitive deficits. And finally, the diagnosis is made by consensus or a best estimate diagnosis. Treatment consists of a combination of social, psychological, and medical interventions. Therapy can be used. Cognitive behavior therapy is being increasingly used in higher functioning individuals. Antidepressants can be used. There is some thought that antidepressants are not effective. This is not true, at least in my experience. They are not effective in those perhaps who have other complications, but certainly in those who have depression, it is effective. There is some suggestion that depression tends to linger on for a long period of time in those who have autism. This may well be true, but we don't have enough data to support this. In refractory cases, that is, in cases who do not respond to usual interventions after a reasonable number of trials, mood stabilizers and other interventions have been used. Even ECT can be tried. So to conclude then, as we reviewed earlier, autism disorders are lifelong conditions, and during the journey, people with autism experience several challenges in their childhood. As far as psychiatric, emotional disorders are concerned, ADHD and disruptive behavior disorders are common. However, as they step into adolescence and adulthood, they are more at risk of developing depression and related conditions. There are some reviews that have suggested that people with depression are 4 times more likely to go through depression in their lifespan compared to those who do not have autism. Later on in their early adulthood, they are also at risk of developing the complications of depression or the complicated course of depression, characterized in some cases by psychosis and catatonia. So the take-home message is that autism can develop together with depression, can occur with depression. In high-functioning autism, the symptoms resemble those seen in the general population, whereas in those who have intellectual disability and communication deficits, the symptoms resemble symptoms consist mostly of biological phenomena such as weight loss, problems with communication, incontinence, etc. Treatment incorporates all modalities, including medications. But an important point to remember is that family support, family therapy, family education is extremely important. Treatment of parents may be necessary if they themselves have depressive symptoms or other emotional problems, just as the health of siblings should also be taken into account and given due attention. And the whole purpose of this exercise of diagnosing, suspecting, and treating depression in people with autism is to improve not only the quality of life of the affected individuals, but also that of the entire family. That brings me to the end of my presentation. I should have declared my conflicts of interest when I started the presentation. I do receive book royalties, and this is the only conflict I have with today's presentation. And that brings me to the close. Thank you all very much for your patience.
Thank you very much, Professor Mohammed. It was a very, very nice and comprehensive presentation about depression and all other comorbidities with autism spectrum disorders. I really like your way of expression, and also I would recommend your second book, In the Middle, which was because I read it and it is very, very good written. And also now I can officially invite you, if you have some unpublished data or some review article for Journal for Real Touch Therapy and Development of Diversities. Also, I would like to invite the participants to give you some comments or questions. In the chat until now, there was no any question, but we will wait for a while. Probably if someone wants to give in live with camera and with audio, we can permit that. Now I will switch on Macedonian a little bit. Значи, повелете, за да не го задржуваме професорот уште долго, веднаш поставете ги прашањата, бидејќи немаме многу време, сепак кај нејфе се уште трае работниот ден и оно одвојеве 1 час од прилика, плюс минус, да биде на располагање. The issue of depression is a very interesting issue, and I think that our audience, we have in one moment 115 participants. It is much more clear to them this issue. And also I like your introduction about epidemiology. For me, everything is known, but probably for some parents or some younger colleagues, it was very good overview of the state of art in autism field. Now we have one question from Irena Stoyanovska. She is my master student and she works on her master thesis. What can, beside the clinical assessment, help guide the clinician toward diagnosis of depression in persons with autism? How reliable are conventional questionnaires or interviews, as they are validated in the general population and not designed for people with autism? And third one question from her, are some of the instruments you mentioned suitable or validated for people with autism?
Thank you very much. That's an excellent question. It must be admitted that most of the instruments are not validated in persons with autism, even in the Western countries. With that caveat, and despite that weakness, I think people do use them. If nothing, it helps us to collect some data that otherwise we would be missing. But the point is well taken that they are not, most of these instruments are not validated. However, that should not stop us from using them, even if that means that we have to translate them into local languages by the bedside.
Yeah, of course. Okay, one more question from one of my master students, Nada Dupyachanet-Nikolska. Do you think that mostly girls with ASD can be misdiagnosed also of depression?
Again, thank you very much for that question. As I'm sure many of you know, that girls have slightly different kinds of symptoms compared to boys. And as they grow older, in general, girls are more at risk of depression. After puberty, as you know, the risk of depression increases in women, whereas before puberty, the risk is equally distributed between men and women. So boys and girls are equally affected before puberty, but after puberty, the risk of depression increases, the prevalence of depression increases in girls across the board, with or without autism. Now, it is possible, therefore, that depression or sadness is more likely to be missed in girls who are also depressed, because the diagnosis itself may be missed. Diagnosis of autism, especially in higher functioning. And the second possible reason is that the symptoms of depression in women in general might be slightly different, and that might also contribute to the difference. So in answer to your question, a short answer is that yes, that is likely.
Yes, thank you very much for all those interesting questions and for all your precise answers. The third question is, do you use ABA therapy for children with autism?
Well, I'm not an ABA therapist. I don't use it, but we all use principles of behavior therapy in our clinical practice. Mm-hmm. So before we talk about ABA, we have to be very clear what exactly we mean by that. If by ABA, we mean the traditional model of using 40 hours a week of intensive therapy or 20 hours a week, then that is simply not possible these days in most cases for practical reasons. 40 hours a week simply means 9 to 5. However, if by ABA we mean using behavioral therapy principles and incorporating them into our practice, then yes, I think we all use behavior therapy and by extension, some principles of ABA.
Thank you. Are there any other questions, please? We are going to the end of this webinar. Yes, we have Elisaveta. Do you have information of prevalence of psychosis in children with autism?
Great question. The question is what is the prevalence of psychosis? We do not have any firm figures because it depends partly on how you define psychosis. As I'm sure many of you know, that in the beginning, when autism was first described, it was described as a form of psychosis, as a form of childhood schizophrenia. It was only in late 70s, early 80s that the distinction was made between schizophrenia and autism. So as to the exact question, what is the prevalence of psychosis? We don't know the exact figures. In clinical practice, do we see it? Yes. We see many children who are referred with a complaint of hearing voices and seeing things. However, do they all have psychosis as traditionally defined? Probably not.
Yes, psychosis is very wide diagnosis, and very several entities belong to psychosis, and it is very difficult to count the percentage of association between ASD and psychosis. And now, one question from one mother of a child with autism. She wants to ask you for advice. How can parents avoid their depressive episodes in the everyday life with child with autism? Prevention of depressive episodes in the parents. How can they fight with depression, with their own depression or depressive episodes?
Well, thank you very much for that question. That question really goes to the heart of the problems which many families face. If not for the treatment of depression, at least for the treatment of stress or stressful situations. Unfortunately, even in the US and other industrialized countries of the West, much attention is not given to parents and their emotional needs. I'm not sure how it can be absolutely avoided, but certain things can be, certain steps can be taken to at least decrease the likelihood. One is by increasing the availability of services to parents, parent groups where they can interact with other parents, increasing the number of hours the policy makers and in our country insurance carriers and other service providers can provide to the child in their house, like babysitting arrangements, increasing babysitting, child minding for the children, decreasing the problems that children with autism face, improving access of the child to school for the X number of hours. So these are the factors, or these are the steps that can be taken for the child, for the patient himself or herself. Parents themselves have to take care of their own mental health by staying engaged, forming groups for mutual support, seeking counseling, not hesitating to talk to a professional if they are feeling down in their mood, not to dismiss that as being stressed or stressful situation. I see many parents, many mothers in particular, because mothers are usually the primary caregivers, as you know, experience sadness and depression. And when they go to professionals, one of the statements they hear is that, what do you expect? you have a child, so you must be depressed. You have a child with special needs, so you must be depressed. That is not always the case. There are many parents who themselves may be at risk of depression because of family genetic reasons, because of social reasons, because of financial reasons, and the policymakers should try to involve social services, educational services, and mental health services in trying to look for the early signs and clues for depression in parents.
Thank you for these answers and for advices. I hope that the mother will be satisfied with this. And one more question. Professor Газиудин, can you please share your opinion or possibly experience on treating children, people with autism with antidepressants or mood stabilizers in the absence of apparent or ascertained diagnosis of depression, anxiety, or OCD, or convulsive disorder? Thank you. Medical question about antidepressants and mood stabilizers in your practice.
Thank you.
What is your experience on treating children with medications and mood stabilizers?
Well, thank you for that question. That the practice of using antidepressants is very widespread in our country, in the US, in general, and now increasingly also in people with autism and related conditions. If the question is, do they respond to antidepressants? The answer in general is yes. Do they respond less or more than those who do not have autism? I think that depends. If the child has other complications, for example, if the child has epilepsy, as you know, 30% of children with traditional autism have seizure disorder, 20 to 30%. So if there are other biological factors, if there are other genetic syndromes, other causes of disability, then the response to antidepressants, by which I suppose you mean the commonly used ones these days, the SSRIs, then the response may be slightly different, if not downright less. There are also some reports suggesting that they may be more at risk of developing side effects. Even for that, the evidence is not very clear-cut. It all depends on the type of autism, because autism is not just one unitary condition. So they are effective, they are useful, they have children experience the same kind of side effects as those who do not have autism. However, when there are other comorbid factors present or comorbid conditions present, then you have to pay attention to those conditions as well, both psychiatric comorbid conditions and medical comorbid conditions.
Yeah, very nice. Okay, I think that we should go to the end of this webinar. I'm very, very grateful to have you today. And also I'm very grateful because you support my work and the work of MNZA and the work of the journal, which I'm editing. And as I told you before, we know each other almost 20 years, but never seen in life. And I hope that in the near future, when this bad episode with COVID-19 will end, but it seems like never-ending story. Let's be optimists. Probably next year or 2023, that it will end finally, and to have you, because last year you was planned to talk on our conference in June, but it was cancelled from reasonable reasons. And I hope that we have 115 participants in one moment. I hope that our collaboration will continue in the future. We as MSSA are open for collaboration, and also you are open for collaboration. I know that on your Ann Arbor University, which is 17 ranked university in the world, and also it's a big honor to us to have you. We have a lot of Macedonians who are employed on Ann Arbor University. I know two of them who works, one she's radiologist, and her husband is gastroenterohepatologist, and also there are probably 10 Macedonian doctors who work on your university, and I hope that they enjoy to work at your university in Michigan. Okay, now I know that your work day is on the middle now, and if you have some other obligations, you can go, or if you want to, you can stay to listen our guest today, Matej Nikolski, who will play one more song from Beethoven. Moonlight Sonata is the name of the song. I know that a lot of you knows this song, but now it's very good to hear the expression of one young adult with Asperger syndrome. Okay, from me to you. Okay.
Thank you very much, Vladimir. Thank you for the invitation. Thank you, everyone, for inviting me. Thank you for your patience to listen to a topic such as depression. Depression is probably an appropriate topic in these days of the pandemic, but I hope the depression of the pandemic will also lift one day, and we will see a ray of hope soon. And life will get back to normal. Yes. And I would have loved to stay longer for your evening, for your presentation, but here, as you know, it's 12:15, and I have an appointment to prepare for in another place.
Yes,
so
we are finishing one more song. Okay, let's I hope that you enjoy, and people enjoy.
It was very nice.
Yeah,
Thank
have a
you very
good
much
afternoon, and take care of your health, and stay safe.
Thank you. Thank you, Matej, also. It's a great performance.
Yes.
On the piano. Thank you. Bye-bye.
Bye. Сега преминувам на македонски јазик. Повелете, млад господине Матеј, вклучете го вашиот микрофон, потоа видеото, подгответе се и почнете. Значи, како што кажав, тоа беше Moonlight Sonata. Се надевам дека нашите гости, кои што исто така ги има во голем број, 100 во моментот, ќе имаат прилика да слушнат нешто исто така пријатно за овие попладневни часови во ова се уште летно попладне 16 септемвриско. Потоа ќе се одјавам дефинитивно. Значи, еве сега полека јас го исклучувам своето видео и микрофон и препуштам следните 3-4-5 минути на Матеј Николски. Феноменално. Феноменално. Мислам дека зборот уживање треба да доживи уште некој степен за да биде поголемо описот на чувствата. Ретко се наежувам, сега се наежив и мислам дека пред младиот господин Матеј Николски е одлична кариера. Му посакувам навистина успех на факултетот за музички уметности, каде ќе работи како корепетитор. Он е еден апсолутен слухист. Изминативе денови бев во одлични преговори со неговата мајка, со која го договоривме овој настап и воопшто сметам дека ние како МНЗА не сгрешивме и ова ќе биде една наша практика и во иднина, да се надеваме дека ќе имаме прилика и во живо да го поканиме некогаш на некоја наша конференција, некој семинар, некоја обука, работилница, каде што ќе може вака да не релаксира. Предпоставувам дека уживавте во сите негови 3 номери и на отварањето и на затварањето. Не би должел многу после оваа одлична номера, мојот рапав глас не е баш благопријатен за сите вас, но само ќе кажам дека благодарам на тимот, како што каже и колешката Допјачанец Николовска, од 4 дами, кои што се секогаш заедно со мене. Овој пат не толку многу експонирани, беа во позадина, следеа слика, ќе ги видите и сликите, наскоро се пушташе вебинарот во живо, ќе може да го видите во YouTube Live, доколку на нашиот канал, доколку се вклучивте подоцна или кажете им на ваши пријатели и колешки колеги, доколку го пропуштиле да го проследат на нашиот YouTube канал. Она што можам да го кажам е дека почна школската година, бројот на COVID расте, за жал, ќе почне сега и академската година, и мај, јуни и во август конференцијата и овој сега вебинар, мислам дека направивме една одлична серија и не можам да ви ветам до крајот на оваа година нешто слично, затоа што навистина сме доста оптеретени со обврски. Ќе биде навистина чудо ако успееме до декември да организираме уште нешто вакво, но да се надеваме дека во 2022 ќе имаме можности повторно да се гледаме. Ако се укаже некоја прилика да направиме 8ми вебинар, ќе го направиме и оваа година до декември, но верувајте дека минимум месец до 2 ќе сакаме малку да одмориме и ние, а и вас да ве одмориме од нас, да не претеруваме премногу, за да не бидеме после да се случи некому да бидеме досадни. Ете, се приближуваме кон самиот крај. Одлични коментари читам во четот, како за професорот Газиудин, така и за младиот Матеј. Верувам и ветувам дека соработката со него ќе продолжи, дека ова беше прв пат да учествува на наш вебинар, но не и последен. Дали ќе биде вебинар, дали ќе биде во живо, и исто така тука можам да објавам до сите родители, доколку имаат деца кои што имаат надарености, не мора да е тоа свирење на пијано, било што да можеме да ги вклучуваме, а со тоа како МНЗА да дадеме придонес кон вистинската и реална инклузија во општеството на лицата со аутистичен спектар на нарушување, како со класичниот аутизам, така и со Аспергер синдромот. Навистина, доколку имате некоја стихотворба, некои цртежи ликовни, па да ги испрезентираме тука на паузите или на почетокот од некој лице со аутизам, ние тоа ќе го сториме со голема радост. Ете, толку, да ви посакам да останете во добро здравје, да се чувате од разни болести, најмногу сега од COVID, но не ги заборавите и другите болести, затоа што има и други болести, не е се само COVID. И да се видиме во некоја наредна прилика, не знам кога и не знам каде, но најверојатно е дека ќе биде на Zoom, пошто не верувам дека до следното лето ќе можеме нешто во живо да направиме. Ете, тоа е толку од нас, толку од мене, како модератор денешен, како домаќин денешен, веќе скоро час и половина сме заедно. Се гледаме во некоја друга прилика, ако не 2021, 2022 сигурно. Ете, толку. Останете во добро здравје и пријатно уште еднаш од мене. Полека ја напуштаме платформава Zoom.